Hello and welcome to the Complex Care Journal Club podcast. My name is Kathleen Huth. I am a pediatrician at Boston Children's Hospital and your host for this episode. In this podcast series, we seek to discuss emerging evidence in the care of children with medical complexity and its implications for practice. I'm delighted to have Dr. Lorna Fraser from King's College London joining me today. She is the lead author of two articles that we'll be discussing today. The first is Your Tube, the role of different diets in gastrostomy-fed children, baseline findings from a prospective cohort study published online in Developmental Medicine and Child Neurology in November 2023. And the follow-up paper, Safety, Resource Use, and Nutritional Content of Home-Blended Diets in Children Who Are Gastrostomy-Fed, findings from Your Tube, a prospective cohort study, published online in Archives on Diseases in Childhood in December 2023. Dr. Fraser, thank you so much for being here.
It's my pleasure. I look forward to discussing these papers with you.
Great. Well, we'd love to just start by asking you what prompted your study? What gap did you and your team identify?
So it was noticed very much within our clinical community over probably around the last decade that more parents of children who were gastrostomy fed had started and chosen to feed their child a home blended diet rather than the standard National Health Service prescribed formula feed. And that had actually been taken up by the National Institute for Health Research, which is our government health funder. So they had a commissioned research call because they decided this was a priority, that they wished to have high quality research study answer some of the questions that we didn't currently know at that time.
Your study aim from the paper was to determine the risks, benefits, and resource implications of home blends versus a formula diet, which was more standard practice for children using gastrostomy tubes. Can you tell us a bit about the methods that you chose?
So the first part was actually a qualitative study where we worked with parents, young people, and professionals to make sure we understood the important outcomes that we needed to measure in the prospective cohort study. And that was really important because quite often studies will measure what is important to our National Health Service or what is important to health professionals, but we know from speaking to parents and children, what matters to them may be slightly different. And it was really important from the funder's point of view that we measured both what was important to parents and children, but also what was important to healthcare professionals and the NHS. So that was the first part of the study, followed by a prospective cohort study. Now, the design of the study was determined by the funders themselves. They didn't ask for a randomized control trial. They recognised that would have been difficult in this situation. So the two papers that you're referring to in this podcast come from the prospective cohort study, which we started about 6 months before the global pandemic. So you may understand the implications that had for our study. Our original aim was we were going to recruit 300 children and their families and follow them up for an 18-month time period and collect data from them at baseline, 9 months and 18 months. Because of the pandemic and the fact that all research was stopped within our NHS for a period of approximately 6 months, our recruitment target was reduced to 180, and we still took data at 3 time points, but it was 0, 12 months, and 18 months.
Yeah, we've certainly seen a few times on this podcast, people have spoke about the implications just that the pandemic had on study design, recruitment, and a number of research choices that needed to be adjusted. The piece that you spoke about at the beginning, I just think that's so unique, really the range of outcomes that you looked at and how you had selected them, that sort of qualitative work. Can you tell us a bit about the key outcomes in your study that you ended up identifying?
Sure, absolutely. So the primary outcome, which we had expected but was confirmed in the qualitative study, was gastrointestinal symptoms. And because there is a validated measure, that was felt to still be the most appropriate primary outcome. But there was a large number of secondary outcomes that were identified by both parents, children, and professionals in the qualitative study that included important factors such as sleep for both the child and for the parent, quality of life, psychological well-being, but also some more of what we would call distal measures, such as participation in daily life and education. Unfortunately, we had to make a call about how much was actually feasible to collect. So we were able to collect our primary outcome, which was around gastrointestinal symptoms using the PEDSQL GI score. We also collected quality of life of the child and the parent. We collected sleep of the child and the parent, as well as quite a lot of other clinical and demographic factors. We weren't able to collect in this study some of the more distal outcomes about participation, etc. But we have published those in our qualitative paper so others are aware for future studies. What was really critical in the methods of this study was working closely with parents. We talk about PPI in the UK, so parent and patient and public involvement, and they were involved from the design of the study, through the conduct of the study, through recruitment, through to interpretation and dissemination. And it was because of that input that we were able to recruit successfully, particularly with the pandemic. So I was concerned if all the data collection was mostly electronic, but it would have failed the thud test if you'd printed it out. And we were asking for a lot of information from parents, but they wanted to provide us that information. Because of the restrictions in the pandemic, we had to flip halfway through to some of the measures that we were going to ask the clinicians for, such as mid-upper arm circumference. We've got a nice YouTube video of me measuring it on my child so that parents could do it, and they managed very well. So I think there were some real positives about the pandemic and learning for future studies that actually these parents amaze me every day with their willingness to participate in research when they already have very, very busy and uncertain lives. But they can really help work with us as partners on research studies.
Yeah, I'd noticed in both papers there was actually an explicitly labeled section called patient and public involvement, which I think is such a lovely model. It's just a reminder for teams to be speaking to how those components are intentionally integrated in design, carrying out the methods, and also the interpretation. Can you speak a little bit about just the logistics of working with an advisory panel and how that collaboration, what it looked like with your study team?
Absolutely. So at the point where we started the study, I was the director of the Martin House Research Centre at the University of York, which was a collaboration with our local children's hospice. So we had a number of parents involved in that centre whose children were alive or who unfortunately children had died, as well as a broader group of parents from the very active home blended community within the UK. Because they were geographically spread, we did a lot of our communications online, and they really genuinely did inform lots of stages of the study. They chose the name, and it was very much came from one of the parents stating very clearly that nobody told me our children were the same age and nobody told me what I could feed my daughter, but people were trying to tell her what they could feed her son. So that's where your tube came from, which I thought was very powerful. You do have to manage these situations. We must be able to reimburse the parents in terms of for their time financially and for childcare if they need childcare to be able to participate. And we also there needs to be a balance in expectations and be really clear about why we're asking for their input, make their views feel valued whilst acknowledging we can't do everything that they might want us to do. Science and research is difficult. It's not always able to do exactly how they might like it to do. But really importantly, them feeding back to them so they understand what changes their input has made. And I'm now really grateful to the relatively large group. I've probably worked with 40 or 50 parents over a lot of our studies, and we have some now as co-investigators, so as part of the research team, and they challenge us, and that is a very good thing.
Can you tell me, in addition to selecting the key outcomes, can you give just one example of either a direction that maybe the study took or a choice that was made that was influenced by guidance from families or patients?
Probably the most critical thing was around recruitment strategies. So the parents were very concerned about our initial plans to only recruit through healthcare professionals because they felt there would be a lot of gatekeeping going on. So with their support, and we needed their support to get through the research ethics committee, was to use quite broad social media recruitment to this study as well as recruiting through healthcare professionals.
I've actually heard that for a number of other studies locally, just kind of making that choice to not be just using maybe more established family organizations and professional organizations, but also thinking about more of the, I guess, grassroots or places to get family voices engaged that may not otherwise be linked in to the health system.
And that's really important, particularly thinking of the diversity of the parents that are able to participate. And we want to make sure that what I call easy to ignore voices rather than hard to reach have the opportunity where possible.
Yeah, that's a powerful way to put it. Can you summarize the key findings of the cohort study?
The main findings from the cohort study are comparisons at baseline showed two main factors. One was that the main difference between the group of children who were on a home blended diet and the group of children who were formula fed was in relationship to their socioeconomic status. So you were more of the children who lived in areas of lower deprivation and whose parents had higher education. They were more likely to be in the home blended diet food group compared to the formula group. We also showed at that point that the GI symptom score burden was lower in those in a home blended diet group. I want to make a really important point here, though. This study was aiming to show that they were as safe and as effective. We were not aiming to show that one is better than the other. And that's because we understand using a cohort study that we have to be careful about particularly unmeasured confounding and differences between the groups that we may not have been able to account for. The other main findings are that the diets were nutritionally similar across the formula and home blended, apart from two main factors. In the home blended diet group, they tended to have higher fibre, which may fit with their lower GI symptoms. They also tended to have lower vitamin D. That is very similar to the general population of children in the UK. And as you may be aware, the public health recommendation is to supplement all children with vitamin D anyway. The other findings in relation to resource use is that the cost to the NHS and statutory sector is higher in children who are formula fed, and that's predominantly because the cost of formula to families is free. The NHS pays for formula. The cost to families was higher if their child had been fed a home blended diet. That was partly due to the cost of blenders and potentially the cost of food, although the latter was very difficult for parents to really quantify because often they were buying food for the whole family. But it was also in the time, so they did spend more time preparing food and spending time doing that than families who were formula fed. I think you have to be careful as to whether that's a positive or a negative, and that might be very variable for each family. So, overall, our conclusions were that home blended diet appear from this study to be as safe and have a similar nutritional content to children who are formula fed and therefore should be seen as a choice unless clinically contraindicated. And we know there are some very rare cases where that may be the case.
I had a chance to connect with Dr. Bridget Ron, who is lead author on a study in 2019 that you had cited. They had a cohort of 70 children who were tube fed and found less GI symptoms in those on the blended diets compared to formula. And we were both at Boston Children's, so we had a chance to discuss your work. And she just commented on how exciting it was to see your study with a much larger cohort on another continent using the same validated measure for GI symptoms, and also finding again that there was less reported symptoms for children on home blend. And so nice to see this contribution to the evidence base in its favor.
Absolutely. And we did take note of that paper when we were deciding our final data to collect to make sure that we were able to, where appropriate, compare or contrast.
You had mentioned that families using home blends have higher levels of education, live in areas that you had classified as having lower deprivation, and also just noted about more time being spent devoted to childcare by the families using home blends, which sort of raises that question of issues of equity around this as a management option. Curious your thoughts on how we can address some of these differences in access. Can we make this option more available to those who might benefit from it?
Yeah, and I think there's multiple factors at play here. When this study started, the main professional organisation within the UK, the British Dietetic Association, and ESPGHAN, the European Association, neither were supportive of home blended diets. During the time period of this study, both have shifted and are probably more equivocal, but are still calling for more evidence. And for some parents, they will find that quite important if their healthcare professional is not able to support them, then they maybe can't do their own research and they maybe don't want to feel able to do something that appears to be counter to what they're being recommended by healthcare professionals. So that's one factor. I think the financial factor is very important in the UK. We have a healthcare system that is free at the point of care. If there's a cost saving, if you like, from children not being prescribed formula feed, then is there a way or a mechanism by which that can be converted into financial resource for families in terms of buying the blender or in terms of the food or any additional equipment required for home blended diets? I think What was difficult to articulate in the paper, but whenever I present these findings, I pose a little bit of a challenge to the audience around, we're talking here about making this a choice, should parents feel able to do this, but we understand because of the additional time and resources required, that won't be right for every parent. And how do we stop this becoming yet another stick, that we beat parents who already have huge expectations on them, and unpredictability in terms of the level of care that they're providing to their child. And I think that's a really important message to get across as well. It should be a choice if families feel able. If we can do something about the financial equity there, then that's one thing, but that may not address all of the challenges in terms of time and resources.
Yeah, you had mentioned, I mean, certainly we have very different health systems. What we had discussed as a co host group, just even opportunities like having a blender being covered as a piece of medical equipment and what that might do to help alleviate some of the financial burden and make this more feasible. But I love just your general message about presenting this as a choice and ensuring that all that thoughtfulness goes into the clinical decision making and the appropriateness for each child and family. I think that's a great message. Do you have any other messages for patients and families from your work?
We have produced two animations, which I can share, two 90-second animations, one for professionals and carers and one for children and young people, where we give them the key messages around the study that I've already shared with you, but also encourage them to speak to their dietitian, pediatrician, whoever is the appropriate person, about if they're interested in home blended diets and how appropriate or relevant it could be for them or their child.
Oh, that's great. Yeah, we would love to link to those resources. We'll put them in the descriptions for the episode. Thank you for sharing that. You had mentioned a number of the professional organizations that are weighing in on this as a management choice. And in the United States, there was recently released the practice guidelines for blended feeds by the American Society for Parenteral and Enteral Nutrition. So I think this is getting more and more traction. And just wondering, with this addition that you've made to the evidence base, what do you think are the implications for clinical practice? And specifically, what do you recommend for members of the interprofessional care team for children with medical complexity based on your findings?
I think our findings add to what was quite a small body of literature. And I think the main concerns from the professional organisations were around safety risks. And we've shown that there is no increased risk in safety events such as blocked tubes or gut infections in this cohort study. So hopefully that in some way should be reassuring. We've also shown that the nutrition can be similar if you're using a home blended diet. I think there still needs to be some guidelines and recommendations about advice to parents, particularly around supplementing diets. What I hope happens is that these papers are incorporated into the next iteration of the guidelines from the professional organisations, because we're starting to answer some of the questions. I think there are some still outstanding questions that are yet to be answered, though.
I guess that being said, what do you think are the next steps from this work?
So I guess there's two main things for me. One thing that we hope to do as part of this study but couldn't get additional funding for and would have probably been impossible due to the pandemic was testing microbiome samples, because I think understanding the relationship between the diet and the GI symptoms is really important. We've partially got that in terms of the macro and micronutrients, but I think the role of gut microbiome I think will be very important. My second comment is around the role of commercial companies and the development of prepackaged blended diets, which many of the big commercial companies are starting to produce. We also have in the UK a couple of parents who have started their own commercial companies for prepackaged foods. And for me, the big question is, when is it coloured formula? And therefore, the outcome is not likely to be different from formula for the child. And when is it as similar to home blended diet? And that would need a different type of study than the one that we have taken. And I think that's is quite an important question that needs to be answered.
Yeah, I think some other studies looking at blended diets include both home blends and the more commercial blends in one category. And I know that there's, sometimes differences in viscosity, which may impact clogging for different home blends versus even just different types of commercial blends depending on the components. So it seems like there's maybe a little bit more nuance or work that can go into understanding those differences and when each might be appropriate.
In our study, we did have a small number of children who some of their feeds came from commercially produced products, but at the time of the study, there wasn't a huge availability of commercial products in the UK. And for me, it's really around the preparation of those products and what needs to happen in terms of them to have a shelf life,
Right.
in terms of what that's likely to have done to the content of the product.
I've just been struck by the thoughtfulness that has gone into each stage of this, from thinking through the outcomes that matter to the thoughtful interpretation of results. And then, as you're speaking to the dissemination and how you've developed resources specific to sharing the messages with patients and families, do you have any advice or lessons learned to share with other researchers in the field about your approach?
I haven't ever actually, working in academia for the last sort of 14 years, I haven't ever done a study without the input of parents and or children, if appropriate. How that has evolved over as time, it's only in the last 5 years I've had a parent co-applicant, for example. But I think do listen to your parents, do get as diverse a group as possible, and value them and listen to them and let them help you. So the animations that I mentioned were made by a commercial animations company, but the parents were part of the team that commented and inputted around the design and the messages and how clear we got the message across. And that for me was really interesting because for some of the parents, it was tricky not to want their own personal experience to come across in that animation. And we wanted to understand that, but it had to be the research findings that were to come across. So it does take time and it takes resource to work with parents and children in a really meaningful way. And it's something that in the UK, you can't get research funding without doing that anyway. But that's not my primary reason for doing it. I'm here to undertake high quality research that in some way contributes to better care for children with very complex and life limiting conditions and their families. And you can't do that without working closely with parents and children.
Well, that's a wonderful message to end on. Is there anything else that you want to share with our listeners?
I just want to take this opportunity to thank the children and their families and the healthcare professionals that participated in this study, because we couldn't do it without their input and they were very generous with their time. So thank you.
Thank you so much for your time, and thank you to you and your team for advancing the field of complex care. And thanks for listening to the Complex Care Journal Club podcast. We aim to highlight research that has the potential to be practice changing, that values patient and family engagement, is relevant across disciplines and diagnoses, and uses high quality or novel research methods. We invite you to join the conversation by suggesting an article that you would like to see discussed in this podcast using the form provided on the Open Pediatrics YouTube channel. Thank you for joining us.